Hi, I'm Dr. Ng, and many of you might know me as Rowena. I go by my first name for the most part. I'm a clinical neuropsychologist over at Krieger Institute and an assistant professor at Johns Hopkins University School of Medicine. You might see me and my colleague, Dr. Jacqueline Hare. She couldn't make it today, but she's a neurologist, and so she also follows on. We see quite a bit of the families affected by Wiedemann-Steiner syndrome together. Today, I'm going to talk a little bit about our study, the anxiety and Wiedemann-Steiner syndrome, what we're seeing. Again, this is kind of like a preliminary findings, so kind of early emergent findings to help us kind of get guide directions for next steps for research. Okay. So clinical background, I'm not going to talk to you too much about what Wiedemann-Steiner syndrome is. Most of you all probably have got this conversation already with a geneticist, but it's a mutation in the KMT2A gene, which encodes proteins. And it impacts gene expression in the long run. And so generally what we know is there is a high risk for intellectual disability or developmental delay associated with Wiedemann-Steiner syndrome, but that could be very variable. So there's quite a wide range in the kind of cognitive difficulties that we do see. But what we don't know is really the neurobehavioral profile. There has not been a lot of research, although we know some from working with families more clinically, but we see more on a more day-to-day basis. Okay, so our kind of interest was outside of the cognitive studies that you guys might have known that we were conducting at the conference, just to really understand also what are the kind of behavioral functioning, kind of behavioral concerns associated with Wiedemann-Steiner syndrome, because by far, oftentimes we have families that are more concerned about the behavior regulation piece than necessarily managing or compensating and adapting to some of the cognitive difficulties pieces. Okay. Some of our earlier research, and from what we see clinically, we do know that behavior regulation, emotion regulation difficulties are very much common in those with WSS. Again, these are much more clinically observed from patients and families we follow, but not really well documented in research because it's such a rare disease. Most of the studies that have been out are mostly case studies, which is basically following a very narrow subset of patients and using multiple kind of inventories, multiple methods to document this. Our recent study that we published on looking at behavioral functioning and sleep suggests that a large group of our subset actually struggle with affective symptoms, and affective symptoms is broad. It can be anxiety, low mood, but about 63% of our sample had reported that the child had clinical levels of emotional regulation difficulties. And again, emotion regulation difficulties can include more like low mood, anxiety, worrying, etc. Again, so there remains really a lot of what's unknown in WSS, including what types of anxieties that we typically might see in these individuals. Okay. So our aim was just to kind of get a preliminary understanding of like, well, what are the anxieties that we notice typically? We know that a lot of families report this. We know that a lot of families have been in either behavioral or medication trials for it, but we don't really know what are the situational or necessary particular antecedent or triggers potentially for these. And so we wanted to examine the risk for anxiety using a common screening tool, the SCARED or SCARED. They're both, one is for the one with one less A, it's for 8 years old to 17, and 18 and above is for the SCARED. And so we wanted to also look at concordance or the agreements in reported anxiety across informants as well. So we had both the child with WSS and the parent of a child with WSS both completed to get to sense if they're both reporting the same observations, the same types of anxieties that's being observed versus being felt. Okay. Overall, we had total of 18 participants, on average about 15 years old, but it was wide ranging from 80 to 33 years old. So 3 were adults, all the rest were children, adolescents. And again, Christina mentioned this, what's really important is that they're all molecularly confirmed WSS. And what that means is that we have genetic test records to confirm the diagnosis. And why I was shaking my head that that's really important is that when we think about research, think about outcome measures for clinical trials and enrollment in clinical trials. Without those without a genetic test records, it's really hard for us to determine how much noise is there in the data, because there's inherent going to be some variability in data. That's what we know. Just generally on like across genetic syndromes, we see that there's like for some genetic syndromes with more data, more publications, with more literature, we still see some variability. And so it's really important for us to know if the variability is truly variability because of a genetic syndrome versus is it variability or noise from any additional genetic kind of anomalies that we don't know of. Okay. And so we had, like, you might have, some of you guys might have had me kind of repeatedly ask you for things. And most times I don't ask for questionnaires again, but I do ask for genetic test records because of that. But what's really important is all of them were confirmed with WSS. None had alternative or additional genetic mutations that could explain for this. So we have ruled out and excluded data for other individuals who might have multiple genetic anomalies, because we, again, wanted to make sure what we see is specific to this mutation in the KMT2A. Okay. We had their parents and child each complete a self versus caregiver report version of the SCARED. Again, the SCARED for is 41 items for 8 years and older, and SCARED with 2 A's is for adults. It's 44 items. The difference is largely that the younger child one has a school avoidance, kind of like school fears kind of category, versus the adult version doesn't have that. And they're all reported in a 3-point Likert scale. So you might have an item where you report not true, it doesn't seem reflective of a child, sometimes true or very true. And it yields 6 scales. So panic symptoms, so these are more like somatic symptoms like heart racing, sweaty, feeling dizzy when you're anxious. Separation anxiety disorder is when you have fears of like having to leave parents or like having to transition into new environments. Generalized anxiety is kind of like considering like future worries. So you're kind of generally worrying about what will happen next. Social anxiety disorder being more fears of interacting with other children, interacting with new people. And then of course, school avoidance is more fears about school related activities. So like going to school, exams, kind of performance based. So overall, our results, we had families also do a research intake questionnaire, which we inquired if their child have ever been diagnosed with anxiety disorder. And 50% of our families have reported actually their child had a diagnosis of anxiety disorder in some form. 50% also reported that they had behavioral therapy for anxiety related concerns and or repetitive behaviors or rigid kind of thinking. And about 57% have reported medication for a psychological concern. So it could be mental health, could be attention, could be concentration, etc. Okay. And again, a large proportion of our participants actually in the self-report reported anxiety, but a little bit less so with parents. And generally what we see if you look at around, so these percentiles are all kind of like how much within our sample reported a clinical level of anxiety. As you can see across the board, they're pretty high, but by far what's the highest is separation anxiety. So difficulties in terms of going to new environments without a parent, having to do with transitions, were a little bit reported more challenging from both parents and also from the actual child who were completing the questionnaire. And what's really interesting is also, if you look qualitatively, adults and the older you get, it seems like the anxiety is much more prominent overall. So generally, as they get older, we see that it seems like that their anxiety being reported is much higher. Okay. So there are some concerns in terms of like, again, but one caveat I would say is that like I mentioned earlier, we have a very small subset of adults. And so if you look at the adults here, parents and of adults and self-report, they're almost 100% of reporting clinical levels of anxiety. But that being said, it's a very small sample compared to our like children and adolescents. Okay. And when we look at those who have a history of anxiety disorder versus don't have a history of anxiety disorder, we do see that parent and self ratings are reflective of that. So those who are reporting who a history of anxiety disorder have significant higher ratings than those who don't. But even those who don't have a history of anxiety disorder still have a large spread of those who met clinical levels of anxiety based on a screening questionnaire, which then also tells us that potentially some people who might have not had a diagnosis might have been not necessarily be picked up on when they see clinicians. And so that might be something that they would want to clearly screen for more thoroughly when you see like a pediatrician or a geneticist or a neurologist or a psychologist. Okay. So overall, what this tells us anxiety is a prominent feature in those with WSS. Is very consistent with what our new kind of more recent literature suggests from our paper and a new paper from Durand et al. About a third had met clinical levels of anxiety based on parent reports on both. Separation and transitions are particularly difficult in those with WSS. It seems like that kind of adjusting to changes in routines, adjusting to changes in environments might be more challenging for them, and they might need more support from parents or familiar faces generally. But we want to think about that in incorporating multiple informants when we do evaluate anxiety, because when we see that parents are self-reports are rated higher than parents, it also tells us that you might see different kind of levels of anxiety across individuals who are observing and across who is reporting. And part of this kind of discrepancy between what parent and child report might also be because some of these anxieties questions are felt, right? So they're subjective in the sense that they are individualized on how you feel, versus parents might be rating based on behavioral observations, noticing kind of any kind of dysregulations and what's observable instead. Okay. Again, some of these questionnaires are developed also based on neurotypically developing individuals when they're made for mental health clinics, and they're not really capturing the type of anxieties that individuals with intellectual disabilities or developmental delay may manifest, like those with WSS. So those with WSS may, for example, show more inflexible thinking and behaviors, which we typically see in a clinical settings when we work with those with WSS, and that might be part of the anxiety profile, but these might need to be more further assessed more thoroughly. So what it tells us, future directions, we need to have multiple methods, right? We have to have, outside of questionnaires, ideally, questionnaires are just to kind of help us screen for risk. It is not used diagnostically. And so we want to think about that in addition to a clear clinical evaluation, and also thinking about potentially psychophysiological measures of anxiety. So if you are actually having physiological changes associated with anxiety. We want to make sure that we have multiple informants. So for example, some of you might notice that your child have more anxiety or more behavioral concerns in one context than another. Some has at school more than home, some at home more than school. And so multiple informants will be important when we think about kind of screening for anxiety, and also thinking about the type of treatment planning. And then developmental considerations. Again, we're seeing that such higher levels of anxiety being reported in adults that it will be important for us to kind of think about looking at developmental cohorts, how anxiety might manifest differently in young children, like toddlers and school-age children, compared to adolescents and then young adults. And then making sure that we use and develop screening inventories that really are targeted towards individuals with intellectual disability and or developmental delays, because again, anxiety may manifest in these very differently. So they might be more behavioral than individuals with, we think about neurotypically, where you report anxiety from actually voicing fears. And then also one big part is in the future directions is really thinking about cross syndrome research. So how can we look at this in relation to other neurogenetic disorders where KMT family, that gene, might be impacted? This might be inclusive of Kabuki syndrome, which we do actually know Kabuki syndrome is also associated with higher levels of anxiety as well. Because when we do partner research and look across family classes of neurogenetic disorders, it allows us to start thinking about, well, if clinical trials are effective for one, can they be then adopted and adopted for another? And so it helps us, one, to understand pathogenesis of how the disease happens, and two, understand whether or not specific clinical outcome measures might also work for another genetic syndrome that are of a similar kind of protein being affected. Okay. And I'm happy to answer any questions. I do want to just acknowledge WSS Foundation for providing support for us and helping us recruit all the families for our studies, and also from our IDTCRC, which is our research course at our Krieger Institute. And then, of course, Dr. Harris, Dr. Farner, Dr. Borgensen, who aren't able to come today, but that they're also taking key critical roles in thinking about both behavioral research, and also Dr. Bjornson thinking about more of the clinical trial models. I'm happy to answer any questions or about this research, or generally about kind of anxiety that you might have questions on for your children, or just broadly.
Great. Thank you, Dr. Ng. And before we jump into questions, we'll go ahead and stop recording.